I have the great pleasure, thank you for Paul sharing the story of Glenn, and again, my heart breaks for every suicide that we see because we really feel like these can be preventable. I'm very proud to introduce a video that former First Lady Rosalynn Carter prepared for this meeting on mental health. As you may know, even prior to going into the White House, that she took on mental health as a cause as the First Lady in Georgia. And so we're really pleased to have this video.
I'm Rosalynn Carter. Welcome to the Patient Safety Movement Foundation's 5th Annual World Patient Safety Science and Technology Summit. I applaud all of you here today for your continuing commitment to eliminating preventable deaths and now for improving behavioral health treatment. For 46 years this month, ever since I became First Lady of Georgia and then of the United States, I have worked to advance mental health care. I remain active through my mental health program at the Carter Center, which Jimmy and I founded in 1982. While I have seen tremendous progress during my years in the field, much work remains to be done. The key message I want everyone to know is that today, because of research and new knowledge of the brain, mental illnesses can be diagnosed and treated effectively, and the overwhelming majority of people living with these illnesses can recover. Each year, a staggering 1 in 5 adults in the United States will be diagnosed or affected by some form of mental illness. Nearly half of U.S. counties have no practicing psychiatrist, psychologist, or even a social worker. Suicide remains the second leading cause of death for people aged 10 to 24. Despite the prevalence of these conditions, adequate access to quality services remains a significant barrier to appropriate treatment. Acute hospital care and community-based wraparound services are essential to successful recovery, and significant resources are needed for both. With an ever-increasing scarcity of hospitals of acute psychiatric beds, I am pleased and excited to know that the Patient Safety Movement Foundation plans to tackle this daunting challenge through your Actionable Patient Safety Solutions. I extend my heartfelt appreciation to you for directing your time, talents, and resources to build capacity to ensure that all Americans with mental illnesses can get the help they need to recover and lead fulfilling lives. While I can't be with you in person, I am with you in spirit. I salute your efforts to ensure patient safety, and I wish you great success in realizing your goal of zero preventable deaths by 2020. Thank you.
So we thank former First Lady Rosalynn Carter for those inspiring words and for reminding us that there is much hope in mental health, particularly in these days with advances that we've made. I just want to say this has been such an inspiring conference. It's very energizing. It's great seeing so many different people together. And I also want to say how much we really appreciate the addition of mental health into the conversation about patient safety. Certainly Glenn Saarinen's story, which we saw first, outlines those issues and concerns so eloquently, and we appreciate former First Lady Rosalynn Carter's words as well. I think as with many of the issues that we're tackling, I'm kind of struck by the similarities between sepsis, VTEs, pediatric preventable drug events, adverse events, that there's so many of these things that our society really isn't cognizant of and aware of, and mental health is another one of these areas. So I want to spend a minute just to outline the problem, as I believe there is a significant lack of knowledge. I've spoken to legislators in our own community who are just like, really? I mean, I understood there's an adult problem, but I had no idea there was a pediatric problem. So I just kind of want to outline what we're dealing with and what hospitals are dealing with. There is a significant morbidity and mortality associated with mental health disorders, and most of those are preventable. If you think about suicides, we should be able to prevent every suicide. It's a lofty goal, but this is a conference about lofty goals, so put it out there. If we think about adults, and we think about individuals with severe persistent mental illness, they have a much earlier mortality than individuals without a diagnosable mental illness. In some studies, it's as much as 25 years of life lost due to having that mental health illness, and not due to suicide. It's due to other chronic conditions, and the number one chronic condition that's causing early death is heart disease. There's much work to be done there. We know also from hospital settings that individuals with chronic illness and persistent mental health problems cost more money to treat. They're in the hospital longer days. They're more likely to come back to the hospital. They're higher utilizers of the medical care system for a wide variety of reasons. We also know, as I mentioned, there's significant morbidity and mortality associated with mental illness. Taking depression as one example, there's an estimate that in the next 20 years, one of the leading cause of disability for adults will be depression. In part because we're doing such a good job of treating everything else and we haven't advanced as much in the mental health area. But if you think about that, that's a pretty significant morbidity. Suicide is the 10th leading cause of death amongst adults. And when you sort of figure that out, every 13 minutes in the US, someone commits suicide. We have 3 times more deaths by suicide in the US than we do by homicide. But if you think about the balance of stories about the mental health crisis versus homicides in our cities and throughout our country, there's a great imbalance there. If you look at this last year with figures of 2014, almost 43,000 deaths occurred by suicide in the US alone. And yet, even in light of this severe disorder, we have a crisis in the number of inpatient psychiatric beds that are available, as Mrs. Carter alluded to, and certainly Glenn's story suggested. I was struck by a statistic. In 2015, we had the same number of inpatient psychiatric beds in the US as we had in 1850. Just savor that for a second. And if you think about the number of beds we've been losing year by year by year, that's where we end up with this particular problem. So that sounds bad enough, but what about children? And I think sometimes children are the forgotten ones when we talk about mental health. 1 in 5 children will have a diagnosable mental health disorder during their childhood. If you think about just in Orange County, that would fill up 3 of our baseball stadiums, Angel Stadium, for the number of children in Orange County suffering from a mental health disorder. If you think about the fact that a lot of people don't really think about kids having mental health disorders, what we find is kids tend not to be diagnosed, they tend not to be identified, and they tend not to be treated. And when you add that, and it can take up to 10 years for children to get a diagnosis. Now think about any chronic illness that goes on for 10 years without treatment. How much harder is it to treat? And yet 50% of adults who have a severe and persistent mental health disorder first had symptoms when they were under the age of 14. So if we could find those kids earlier, diagnose them earlier, we actually could make an impact on the adult mental health crisis as well. And finally, as Mrs. Carter alluded to, suicide is the 2nd leading cause of death for 10 to 14-year-olds and for 15 to 25-year-olds. And yet, again, psychiatric beds are not available. In fact, they're even rarer for children than they are for adults, and we know how rare they are for adults. So what does that lead to? What happens is we have a large number of adults who present to emergency departments looking for mental health care. But think about, could we design a worse place for someone in a psychiatric crisis to be? And yet they end up waiting long periods of time looking for placement or being sent home without appropriate supports. We also find that psychiatric patients have longer waits in the ED. Some studies show they wait up to 3 times as long, and it's even worse for children. We've had children routinely in Orange County wait over 7 days for an inpatient psychiatric bed staying in the ED because they were unsafe to go home. So while all this may seem daunting and overwhelming, I was very inspired by Bill Clinton today, who said, you know what, we need to start somewhere. And we're so proud that the patient safety movement has made that first start and developing an apps. And there we go. So I want to go over the summary with you, just briefly. So one of the things is when you have a very rare resource, you have to utilize it appropriately. So one of the parts of the app is to survey and assess the stakeholder support for those who are in need of a psychiatric bed registry. We want to increase and secure buy-in with the key players by continued education of that need. I think sometimes people hear about a registry and they get a little antsy about it or anxious about it, so we want to educate about that. We want to implement a real-time electronic bed tracking system so that, again, with a rare resource, hospitals can efficiently and effectively utilize that resource and place patients in beds that are available. We also want to communicate with key stakeholders who will be using the system to make sure that it works effectively. We also are proposing an ongoing monitoring to maintain the system in order to make sure that current standards and protocols are being adhered to, that people actually are telling us what beds are available. And finally, we want to be able to share data for times when the bed system is full and the needs for psychiatric treatment is not being able to be met. That way, just as we can say for EDs when they're on diversion, we can say that as well with some certainty in data for psychiatric beds as well. I want to thank you guys for your attention to this overview, and I'd like to invite our panelists on stage. All right. I want to thank you guys so much for being here with us, and I'll do brief introductions here. We're very fortunate to have with us a panel that sort of represents all the different areas of mental health treatment. We have, fortunately, with us Dr. Anita Everett, and she is the president-elect of the American Psychiatric Association, and is also recently the newly appointed medical director for SAMHSA. So we're very pleased to have you here. We have Leila Entezam, who is this Chief Strategy Officer for Patient Valet. And she brings a very nice background, but having both a business and a therapist background to bring that perspective to mental health issues is wonderful. We have Monica McAlduff, who's the Director of Mental Health and Substance Use at Vancouver Coastal Health in British Columbia. And one of the ways Monica's working to improve health in psychiatry is looking at care systems and including patients and families in their care and decision making. And Paul, you saw on the videotape, so thank you so much, and certainly our condolences on the loss of your father. And we really do very much appreciate you sharing your story. Paul brings a technical background as well. He's the president of 4Cubed, and that's a video game company. So thank you so much. Unfortunately, Daryl Steinberg had to send his regrets. I think when you're mayor of a city, sometimes things come up. But I know he's very regretful to not be here. So I have a couple questions, but I certainly encourage you guys to put your questions in as well as we're talking. Anita, starting with you, what are some of the key factors? We talked a lot about how the system's sort of overwhelmed and a lack of beds. From your perspective, what are some of the key factors that have contributed to why we have this problem now?
Yeah, so there are a lot of factors that are involved with that. As you mentioned, we have, right now, the very low number of beds the way we count beds is per 100,000 beds, and so we're just under 12 beds per 100,000, sort of on national. There was a time in the 1950s when we'd gotten up to over 300 beds per 100,000, and most other developed countries have much more on the order of 20 to 30 at the very least beds per 100,000. So we are absolutely at a deficit in number of beds. There are multiple reasons for that, one of which has to do with state psychiatric hospital beds having been reduced. And President Clinton mentioned some issues just globally, sort of broadly, with our delivery system now and not having built up enough infrastructure to compensate for the closure of the state hospital bed. State hospitals served everything. Now we have a much more fragmented system that has not built up. The infrastructure is just not there right now. Former First Lady Carter referenced that as well. We just don't have. We know a lot about how to take care of people in the community, but we don't have enough.
Okay. And are there any factors such as healthcare funding or things like that that have contributed to the closure of beds in addition?
Absolutely, right. Absolutely. That's been a major issue. So we have financing that many general hospitals are faced with the idea of wanting to do the right thing, wanting to have psychiatric units. Many persons who have psychiatric conditions are uninsured or underinsured, and so we've had major gains with that in the last, really since the Affordable Care Act and other activities, but we now are at a point where hospitals really are faced with operating units at a deficit often, and so they can't afford to keep units opened because the payment for patients in psychiatric hospitals a lot of times is so low, it doesn't cover costs. Yeah. And that's been the main reason that we've lost numbers of beds, absolutely, over the last 50 years.
Thank you. Monica, you're practicing up in Canada. What are some of the types of support services that your facility offers that can really help reduce the burden on both inpatient hospitals and on emergency departments with patients coming in psychiatric crisis?
Well, something that we noticed with our hospital, VGH, which is our Vancouver General Hospital, is that 30% of people who came to the hospital were admitted, which meant there were 70% of people who came to the ED departments and were never admitted and did not need an inpatient bed. So we were really looking at, and our numbers kept increasing for the amount of presentations. How can we service these individuals in a different setting away from the emergency room? And you mentioned earlier, it's not the best place for anyone to be when they're in a mental health crisis. And so we developed a new program. It was our Access and Assessment Center. So when we had done some patient and family engagement sessions, their biggest feedback was access to services and also information to services so that they could easily have a way to navigate the complexities of our healthcare system. So with our Access and Assessment Center, it was what we opened up was a 24/7, 7 days a week on the hospital grounds, but away from the emergency room, a place for people to come for urgent assessments where they could be seen by a clinician, access to a psychiatrist if needed, and then referred on to our services. We would actually be able to see people the next day if they needed to, or go to their home and see them at their home the next day, up to 3 visits a day, and then transition them to a next level of service. And then if they did need a bed because they were presenting in an acute state, we actually had access to our acute inpatient bed. So we could bypass the emergency, we could go directly up to an inpatient unit. And so we were really looking at how can we support people to maintain their wellness, not needing a hospital bed, so we could decrease the burden on the hospitals and emergency, actually provide more service upstream when people were still able to receive that. But then if they did need to come in, we could access the services. So I think it's been a great service that we were able to provide. I know one of our family sessions, one of the mothers said, "Are you serious? Is this really something you guys are going to provide?" And I said, yes, this is our vision. And we've heard from our family and patients, and we really wanted to provide this. And it was really with existing services. So we had another central intake. We did have some home-based treatment, and we actually had some nurses who would do some ride-alongs with police officers. But we amalgamated everything so we could lean everything out and have our different programs speak to one another, work together, work in one site. So it was really just sort of changing how we could be more customer-driven and provide the right service at the right time.
That sounds like an awesome system. I know I shared with some of the panelists I had worked with a young lady who had made a suicide attempt. Her mother had been trying for a year to try and access services locally and basically said, it's only after this attempt that I know that you'll get her into services,
Yeah.
and to have to wait for that
Yes.
to happen is,
Yeah.
so it's a great thing to have that sort of variety of services. So even with a lot of support, sometimes we do need inpatient beds to really help in that crisis moment.
That's right.
Leila, understanding that a bed registry isn't going to fix all of the problems that mental health brings, but how do you envision that registry would be helpful?
Thank you, Heather. And I wanted to first of all start by thanking the PSM family for just being such a strong partner in doing this important work. So, as you said, we're very well aware that a bed registry won't solve the problem. But as President Clinton said very eloquently this morning about being in the real world, our team has the benefit of actually being in the real world in terms of, I myself, one of the hats I wear is a licensed therapist. We also have a psychiatrist on our group that is on staff at 5 local hospitals. And our other partner has an extensive background as a psychiatric intake nurse. And so with that comprehensive background, we get to see real-time access and availability. We are very familiar with the fact that a bed registry won't fix the problem, but when you have a simple case of supply and demand, and we know that there is limited supply and there's an incredible demand, even if a bed registry gives you access to just one more available bed, so that, as my colleagues shared today, we know the average wait times are 18 hours, 24 hours, 36 hours, longer than we've been in this entire seminar, and a patient now that's been waiting for 6 days. 6 days. That's longer than most of you will take to get here, attend, and go home to your loved ones. Waiting 6 days for a bed, then if that means one bed gets used for one patient, and that makes one difference in a suicide, then to us that's worth it.
That's great, thank you. So having sort of tried to put some of this together, what have been some of the responses from hospitals and partners that you've approached?
So we thought it would be a no-brainer. We thought it would be a very simple task, and we did this web platform. Some of you may be aware in Virginia, it is actually mandatory use of the psychiatric bed registry. It's the only state in the nation that has that. There are other states where it's optional, but Virginia currently is the only one that has it as mandatory. And so we thought it even makes numbers sense, where our platform is so affordable that if you placed one patient one night for the entire month with insurance repayment, it pretty much would have recouped your cost. So even with, from a numbers perspective, it made sense to us, let alone from a patient care perspective. And unfortunately, we did the dog and pony show, as my colleague calls it, and went out to all the local hospitals and even extensively in Southern California, and zero. It was, we don't want the competition to know our bed availability, or we want to be able to put the patients that we want into these beds, or we have other regulatory compliances we have to keep up with, and so we can't add this other duty to our staff. And in a time when technology is literally permeating every aspect of our lives, to be doing something so critical in the archaic fashion of literally calling hospital by hospital, and then when you get to the end of the list, starting again and calling hospital by hospital, just didn't make any sense. So when the dog and pony show failed, we tried the legislative effort, and Daryl Steinberg's team was great in helping us. Eggman had a legislation this past year that unfortunately didn't make it through. But now with the 21st Century Cures Act having federal funding for implementation of a bed registry, we figured if the federal government is willing to give you money for it, then there must be some sort of evidence that it works. And so with federal funding for it, hoping that it may now be better received.
Thank you. Paul, thank you so much for sharing your story, and your family went through so much, and your dad went through so much. Sort of as you've been thinking about this and being willing to share your story, what are some of the things you'd like to see different in the system that you feel like maybe would have supported your dad and your family?
No, thank you again for letting me and my family share the story. I think it's been been a healthy release for us to share this information, and obviously there's 40,000 plus preventable deaths that we want to see reduced to zero by 2020. I think there's a couple things that I take away from this. Number one, and I think bed registries and some of the things that are happening on that side are important to what I've seen in advancements in, we talk on the pharmaceutical side of things. I have a background a bit in genetics, and one of the things I've seen in advancements of the tests that are done to help from a personalized standpoint, matching the patient with the correct antidepressant has been a miracle just in recent years. So I think that's been a great value. I think we're seeing leveraging technology to help these people and get access to care in a more personalized manner. The other thing I think was mentioned in a couple different instances today is the silos in medical records as well. If a lot of these patients are presenting in ERs, as our story told you, my dad was in the ER many times. All it took was one person to look at his record to see that this was not the first time, and that the care was needed. So I hate to say interoperability, because what does that mean anymore other than let's leverage the information that we have, not necessarily more information, but leveraging the information that we have available. So those are some of the things that I think come to mind.
Yeah, that's great. Thank you. I think, and I think this has been true in maybe some other diseases in the past, and cancer comes to mind. But I think there's a lot of stigma still associated with mental health. What role do you think that plays in what the crisis is now? And I'll open that up to any of you guys.
I'll go ahead and start. One of the other hats I wear, as I said, is I'm also a licensed therapist, and I work with a lot of adolescents and families. And absolutely, the stigma that, one of the things I do is I run a group. And so in the group, you see that they're there and they feel felt by their colleagues, knowing that in this place it's safe to share that I have some mental health affliction, I have depression, I have anxiety, etc. And the second they step outside of that safe space, the stigma and all the consequences of it kick back in, and they shut down. And if we could extend the benefit of that by reducing the stigma, then they would feel safe to extend even to their other friends that, hey, you know what, I know you're not feeling well, I have this group I go to, you're welcome to come here and join me, and it's working for me, and so feeling more supported.
Another aspect of stigma is that it many times impedes people from getting treatment earlier. They don't want to be identified, and so they'll wait until years, and they've been suffering and not come into treatment until much later, which means they're much more acute when they come in and much more likely to need inpatient care or much higher level of care than they might have needed if they'd gotten help earlier.
Yeah. And something I would add too, I think sometimes it's really hard for the families as well, only having to see their loved one who's suffering, and if they're not wanting to seek the treatment, it's very hard to get them to seek that treatment. And I do think it is a tragedy when it does become an emergency. We should not be supporting individuals who have mental health issues in an emergency department or in a crisis state. We need to be able to provide that service in a community setting, in a very therapeutic way, so that people, especially if it's their first exposure to healthcare, if it's very traumatic, it's very hard for them to go back, or if they're not being heard or listened to. I think there's a lot we could do around our community and within healthcare even as well, around stigma.
Mm-hmm. No, Paul, if you want.
I think with anything involving medicine, if you can handle and manage this stuff upstream before it becomes a major issue, again, that requires a significant change in some of our cultural norms as well. I mean, because shame permeates a lot of these things, right? And we have to get away from that and the shame that comes along with it in order to handle it before it becomes a problem.
Yeah. I know one of our partners in this, Kay Warren, talks about this as being the no casserole disease, that when your child is hospitalized for other illnesses, everyone brings casseroles and rallies around, and your child's hospitalized for psychiatric issues, and it's crickets. So I think that having that conversation, and we definitely thank Joe and the patient safety movement to have that conversation, because I think that really does help reduce stigma. Is like, let's just talk about it a little bit. Yesterday, Dr. Conaway from CMS touched briefly on the idea of the integration of behavioral health into medical care sort of routinely. Maybe we'll start with you, Anita. What would be some ways what makes that helpful, or what are some ways that would help this problem to do integration?
One big way is it helps to identify things earlier. So when you have the notion there is importing mental health care into a primary care setting or a less, there's many advantages to that, one of which is the stigma. Even in, parking in the same parking lot where you go for your general care is less stigmatizing than have your car park in the mental health clinic. And so there are many reasons that it works better when you can identify and treat things earlier. So the stigma is one part. You can oftentimes catch illnesses before they've gotten worse. And many mental illnesses can be addressed in that kind of environment without higher level care before they become extremely acute. And so it's really caught on nationally to have that sort of emphasis. Particularly in outpatient care, we do that much less in inpatient level care. But
And I think we had talked a little bit about the Henry Ford medical health system in Michigan had applied some routine screening and integration to look at suicides then.
Yeah, their goal was to work on 100% perfect care for depression style thing, and they were able to do that. So they permeated depression and attention to depression care throughout their whole hospital. So surgeons or surgical offices were asking about depression and things like that, and they really were very effective in reducing suicide rates overall. That was one of their ultimate metrics in the community where the hospital was. It's a well-known, very successful program.
I think they reduced suicides by like 80%.
It was tremendous.
Yeah, it was a pretty amazing thing. Monica, for your group, integration into different areas, has that been helpful?
Yes, and it's actually something we're really focusing on. It's really embedding supports in the primary care office, and how does that look like? Because really, if we want to talk upstream as much as possible, it really is with the primary care physician, and it's really that transfer of knowledge and information and having resources available when people first have that conversation with their physicians. So it is something we're looking at. I know with our Access and Assessment Center, physicians can refer, people can walk in, but ideally it would be great if they could be supported in their physician's office, but we're there if they need that next level of care.
And Paul, do you think it would have made a difference for your father to have behavioral health integrated with his primary care provider? Or?
Yeah, I mean, who knows? Maybe absolutely. I think it would definitely have helped, and I think there was a little bit of that as well. I think one of the things that we're seeing as well from a technology perspective is the integration of that mental health awareness piece in the consumer wearables marketplace. So that becoming more the forefront, as we're getting into mindfulness and some of these other trends that are becoming greater as well, that maybe there's more of an acceptance to be aware of how you feel and the things that are happening around you. So where we struggle with privacy and those aspects within these different marketplaces, especially around healthcare, these movements are kind of changing the way that we look at and deal with these problems.
Well, I don't know.
I just want to add one other thing about integrated care. Usually when we talk about integrated care, there's a couple things that are upgrades, I would say, compared to just the primary care scenario that are important. So our baseline is it's 60% or so of the antidepressants that are prescribed in America are actually prescribed by general practitioners or family medicine or internal medicine, not by specialist care. So there's a lot of that in our world. What integrated care brings is a richer capacity to understand the whole perspective of the patient, not just, here, take your Prozac, and maybe we'll check up with you the next time you come back in a couple months. It's a much more comprehensive way of working with individuals. It also usually has a database that tracks people, so it proactively follows people. So it's not just we'll see you when you come, and it's okay if you drop out of care kind of thing. It's an active tracking and accounting for people. So it reaches out to them if they don't come for their appointments. So there's a lot of technology that's involved in keeping that kind of tracking going of people, but it's very helpful. So it's a richer kind of, it's an augmented treatment.
two quick things I would add to that. One is but with integrated care, those are the people that, like your primary care physician, that do have more touch points with you, and so they are going to be more familiar with when something just doesn't seem, norm about you, and so they would be able to more properly and more rapidly speak to, hey, maybe you should sort of get an assessment or whatnot, and also that with the primary care physician then being able to know when to pass it on, when to say, you know what, I'm not sure about your meds, or I think you should see a specialist. A lot of times what I see, especially as a therapist, is someone who's taken the same meds for a long time and their primary just kept renewing the prescription and it's not working for them, or their body has changed, their age has changed, and something needs to change, but the primary just sort of, it's a quick appointment and it just keeps getting renewed. So having a psychiatrist that would be able to speak to that.
Okay, great, thank you. We do have one of our questions from the audience, and Paul, you kind of touched on this a little bit, but I'll ask you guys to expand a little more. From Patty Atkins is, are there any healthcare systems using communication technology, so mobile apps, to improve patient access to mental health services?
Repeat the question one more time.
Are there any healthcare systems that are using mobile technology to improve patient access to mental health services?
Yeah, I mean, I know of several that have done that. The general sort of word on the street, so to speak, among psychiatrists is we need more data to demonstrate the effectiveness of that before we adopt it as a full-on clinical message. Now, that may be part of the conservative part of our profession. We've talked earlier about how long it takes us to embrace new technology. So we know, for instance, virtual case management, can that be effective to extend visits between visits with a clinician where you have a synchronous or asynchronous relationship with someone who can, the person texts a message and you respond back to them within a certain time frame or things like that. So there's several models for that that have demonstrated on a small scale with numbers of 30 to 50 patients, not the numbers that we need to really take it large scale, that they can be effective. Usually it's framed as an augmentation to traditional treatment, but so yes, that's emerging, but we need more data. It would be great to have more funding to develop a harder evidence base behind those.
Something I'll add around that, just next month we're actually going to be launching Kelty's Key, which is online therapy through our outpatient department, where people will be able to have communication through our website and online communication with a therapist. So we haven't launched it yet, and people would be accessing it through our Access and Assessment Center, but I'm not aware of an app for people to access services. I know for our Access and Assessment Center, we have clinicians there 24/7, so people can phone or walk in, which is, I think, a great service, and we do a lot of our treatment over the phone if people need follow-up, if they don't necessarily want to come in. But hopefully soon we'll be talking more about Kelty's Key, and which will be online therapy. Mm-hmm.
Okay. And we also have a question from Lori, who liked your comment that we should handle it before it gets to be becomes too much of becomes a big problem. So she's wondering about ways in which this has been addressed in schools, or that we can work with schools to maybe identify or provide treatment early for children.
Mm-hmm. Yeah, so school-based services there's many different models for addressing that in school-aged children, but school-based services is one sort of way, whereas the integrated care models that we think about historically have been for adults. A counterpart to that may be embedding mental health services in school systems. And so that's not very universally available. It's not very cost effective in most systems. I ran a program in Baltimore that did that, but we had a separate contract from the schools department itself that augmented what we didn't make in regular fee-for-service there. So it's a very important thing. Kids, of course, that's where they are a good third or so of their time, so it's very useful for the kids to capture them in treatment because that's where they are. So it can be very effective.
I know there's also a lot of the school districts that do Mental Health Week, Disability Week, things like that, and offer you the opportunity to go there and present your resources directly to the kids.
I know we actually just received some funding to provide some training and education to teachers in identification as well, because I think sometimes they're a little like, I'm not quite sure what to do. Obviously, we could talk about this forever. I know you guys would probably be like, stop talking. So we really do appreciate so much you allowing us to come and talk about mental health, for creating the first apps for mental health, and we hope there are a lot more to come. Thank you guys so much for your attention tonight.
Thank you.
Ladies and gentlemen, please enjoy the Taste of Laguna dinner in the pavilion. We'll see you back here at 8.